Well, good morning, everyone. I'll introduce myself. I'm Michele Moser from the ETSU Center of Excellence for Children in State Custody.
And I'm Kristin. I'm with the COE in Knoxville, covering Knoxville and surrounding.
So we're really happy to be here and to join you all. And we have been excited about trauma-focused cognitive behavioral therapy since 2007, when we discovered it and partnered with the National Child Traumatic Stress Network to bring it to Tennessee. But we also know there are folks who may know the letters, but don't know what it is because it's in the atmosphere now. So I think we just kind of want to see who's in the room.
Yeah. So do we have any therapists in the room providing direct services? Okay. Workers, like caseworkers. Okay. Perfect. Good. Child advocates, law enforcement, administrators. Yeah. Okay. Okay, good. So show of hands if you've heard the acronym TFCBT.
Yes, we're successful.
Okay, you've at least heard of it, you're familiar with it. So we're going to spend a little bit of time talking about kind of what it is, why we think it's an important prevention tool for children with trauma histories, and then we'll kind of talk about some ways that we adapt it. So as we're going, if we use jargon or terms that are not familiar, or if we say something that makes no sense, which is possible, please ask questions. We want to hear from you. We want this to be helpful for you. So just let us know as we're going through it.
Yeah, that's really helpful because we go around saying TFCBT all the time and the acronyms within the model. And we're a lot of times spend our time with therapists who we've trained. Not as much time bringing the message to folks as we did in the early days. So really do stop us. Yeah, may not make sense. So to get us started, down is up. Yes. These are the two manuals that a lot of this work we're taking it from. The one on the right is what would be called the treatment manual. It's a second edition. This model was starting to be investigated and evaluated in the late 90s. So it has gone through a lot of reform and iteration, making it better. And then one of the things, like when we first brought this model to Tennessee, and people were like, yeah, this model is great, but this doesn't fit the kids we have. Like, we have complicated kids with child welfare. And as we learned more and as the field learned more, there have been a lot of adaptations and development to address some of those special populations. I don't even remember when we did it, but we had TFCBT for residential treatment, and there's some specific things that you considerations for foster care, that kind of thing. So that book, oh yeah, and I brought my prop. I have the book, but it is really a helpful manual or book if you want to kind of learn about those special populations. So for us, we just want to describe the risk of future trauma exposure among children and youth involved in the child welfare system and the importance of providing evidence-based treatment. That's the grounding, and that's why we think of this as prevention. Some folks, like, oh, TFCBT is an intervention you do in the mental health center, but it really is a prevention model. So we want to kind of be considering that, and we're going to explain the key components of TFCBT and the importance of tailoring the components to each family, matching what they need to reduce the symptoms and reduce future victimization, future episodes of maltreatment, and then discuss specific strategies for the adaptation of TFCBT for youth with complex needs. So just a grounding, child welfare. We're all here because of our involvement with child welfare and in this conference about prevention. But we know that there is an increased rate of trauma exposure and symptoms, more than the general population. In Tennessee, we've done a lot of ACEs work. We know there's kids with ACEs, and then in child welfare, we see those big ACEs. A typical kid might have 1 to 3, and in child welfare we got the 10. And so just reminding us that this population, while a lot of our kids have trauma exposure, when we're with the folks that are coming to the attention of child welfare, they have a lot more. They're at risk of one trauma, at risk of more trauma. So that idea that there's just one trauma, and that was what people were pushing back on when we first brought the model. Our kids have multiple traumas, lots of and multiple episodes and kinds of trauma. So we also know that if we don't intervene, that the trauma exposure risk increases for more trauma. We know that in childhood, but we also know that in adulthood that you're more at risk. So it is a prevention strategy that way. And then multiple trauma exposures lead to increased risk of multiple severe outcomes. And again, those are our challenging kids. We're hearing the stories about our kids that are more challenging than they were 10 years ago with all the multiple traumas. So TFCBT is the evidence-based treatment. There's been over 20 randomized controlled trials. And, anytime you want all that data, we got it. But we're not going to talk about that today. So the adaptations we have that they have, and there are actually some other ones, but foster care, residential treatment, developmental disabilities, problematic sexual behavior, parental substance use, and then complex trauma. And I here's my my commercial. The COEs were involved with a national group that brought complex trauma trainings, like what is complex trauma, and then all kinds of specialties. And we actually have 5 of the COEs have folks embedded who can do trainings on complex trauma for specialty populations and just basic. So that's my commercial. That's something else we do that we had the opportunity to be national leaders in. So what is complex trauma? Exposure to multiple chronic and interpersonal trauma at an early age, really. And I think, in Tennessee, we're doing a pretty good job of paying attention to infant mental health those early years and the impact of the caregiver's availability or the interpersonal violence within the caregiving relationship with the child. Those are the ongoing chronic nature. It can include severe sexual, physical abuse, neglect, witnessing domestic violence. And I think we as a system are getting a lot more aware of the impact that witnessing, because before people are like, yeah, they're safe. But what happens to those kids when they see their parent being abused or their sibling or that chronic violence actually has an impact that I think we underappreciated. And we don't have as much of this, but experience in a refugee camp, community violence, folks that live in really unsafe communities, and then, add on those other traumas, really brings us these kids with really complex needs. So complex trauma results in dysregulation. We talk a lot about that, but that is the hallmark. These are the kids that are saying they're going off for no reason. The teacher asked them to do their math homework and they flip the tables. So the resources that kids usually have, to learn in school, to develop their social skills, to develop their cognitive abilities, these kids are so impacted. They don't have the resources to work on what a typical kid does in development. It really slows them down or stops them because they're just working on surviving every minute. And so I think that's one of those messages that as a system, we're getting better at kind of thinking about in schools, what's going on with these kids. Why aren't they learning? There are impacts besides them being bad kids. So the dysregulation can lead to impairments in all these different categories. In their affect regulation, the kind of behaviors we're talking about, flipping the tables and yelling at the teacher and punching the peers. The biology, that chronic stress response that is ongoing, heightened. So that has a physiological toll long-term on health, which we know from the ACEs research that many of us are aware of. It impacts their attention, their cognition, their ability to use their memory, their feelings about themselves as a worthy, lovable kid versus just surviving. And then relationships, we see it, relationships not only with adult caregivers, teachers, peers. These kids are all over the place and really isolated because of their dysregulation. So this is the message that I think that we, as COEs, starting in 2007, we're trying to bring to the treatment community, that idea that these symptoms like that you see in these kids with complex trauma, hypervigilance, impulsivity, what does that sound like? Oh, that sounds like ADHD to the primary care provider. Lack of trust, they're not gonna, I'm a nice teacher. How come this kid's treating me like this, right? So it must be something wrong with that kid. Inflexibility, controlling, all those things that are very challenging for caregivers and teachers and folks in the community. So what do? We say that is an oppositional defiant sort of kid. I tell them to do stuff and they don't do it. So that kid is willfully being bad. Without the trauma lens, that's where you get to, or ADHD. So many of our little kids, they're all over the place. They are hyperactive. They are not paying attention. They get taken to the PCP, and if that's all you're looking for is ADHD, that's what you see. And Chris and I were talking about this. So when we were first doing COE work, all the referrals to the COE about these kids with bipolar disorder, those are the table flippers and the mood, regulation, whatever. We know it was trauma, but the one that we're getting now is every child referred, we need an autism assessment for. Well, what are they doing? They're taking those misunderstood behaviors, inflexibility, controlling, so they could be that. But the trauma lens, again, is, when we're getting these kids with complex trauma, might not be our first thought. But that's kind of where we get to. And then the concern is that if you see those symptoms and you go to your PCP, what are you going to get? You're going to get one medicine, you're going to get two medicines, even going to our psychiatric providers in the mental health center might get too many medicines to address those symptoms. Not where is this all coming from? So we have a system, have seen that if you don't understand where the behaviors are, what the real diagnosis is, that you're going to have inappropriate treatment. And that's where we've been so excited to bring TF-CBT and get so many providers trained over time. So in mental health, we have a lot of evidence-based treatment. They all have letters, ECIT, TF-CBT, ARC, attachment regulation, all of these things. But so the National Child Traumatic Stress Network say, we've got all of these trauma models, and we should do some looking at what are the core components that a trauma model should have for people who are thinking about, what kids need and, what we should apply. So number one, that screening and assessment, right? When you're going to implement a model, good screening and assessment, fundamental. And that's one of the changes that we really did bring to Tennessee. So most mental health agencies do a routine trauma screen. Now we have work to do of using it, but we got it there. And so that's one of the really key components. And then not just screening. So, okay, this kid has some trauma, but really doing a thorough assessment, understanding where the root of these behaviors, what are the things that are impacting that conceptualization, not just the symptoms, those are important, but also how come this is happening? How come this is happening in school? How come this is not happening when they go to the Boys and Girls Club? Really being curious to find where their strengths and needs are. Psychoeducation, again, really important, not only about the impact of trauma on brain development, but what happens to kids who are physically abused? So that information about your own trauma and your own experience is a really fundamental key piece. And then, addressing children and families' reactions, those big blow-ups, the affect modulation. How do you help people center? How do you help them calm? So that's an important component if you're going to have an intervention to help kids and families. And then trauma narration and organization. So TF-CBT has a specific way of doing a trauma narrative, but all of the trauma models have a way of helping kids and families understand what happened and put it in an organized way, not just episodic incidents, but like, how does this fit in what happened to me, what kind of a kid I am, all of that healing part of telling the story. Enhancing emotional regulation and anxiety skills. Again, all the models, you got to have some skill development, right? So that you're not only learning how to deal with what's going on right now, but having those skills to carry on into development. Facilitating adaptive coping. I just talked about parenting skills and behavior management. We got to help the caregivers. You can't have evidence-based treatment for trauma. Treat the kid in your office. That's not going to work. You have to have helping the caregiver change that culture with the child and be the part of the healing. Promoting adaptive behavior, developmental progression, but that's like getting back on track. I can now pay attention in school. I'm not getting F's because I'm so distracted by all the flashbacks. I can actually use the skills I have and learn how to read. Addressing grief and loss, and I think that this one is a real challenging for us kind of, it's over, they were moved, and I think sometimes that's underappreciated, how many loss, not just the loss of this family, the loss of the school you were in, the loss of the neighborhood you were in. If you've had multiple moves and your family is homeless, you lost your, best blanket. So I think sometimes we don't assess so much for that. Promoting safety, yes. I mean, that is one of the key components, like psychological safety, physical safety, safe caregivers, the kids being safe, right? That's a core component. Planning for after treatment, the relapse prevention, they're calling it that, but that idea is like, okay, you've made these skills, and then you're going to have bumps in the road. So, what is going to be your plan when you hit inevitable bumps in the road? And then looking at the evaluation, seeing how kids use that important assessment at the beginning, but also helping families assess at the end and see, like, here is the progress that we've made. And then the last one maybe should be the first one. Really, all of these evidence-based treatments have to really work on engagement, caregiver engagement, child engagement, and barrier busting. Like, what is keeping that family? Like, we often say, oh, this complicated family doesn't get the services. Okay, what's getting in the way? And are there things that we can facilitate to get them there, because we believe in that? So those are just the kind of, like, if we're looking at any model, the core components. So this is TFCBT, and so not that everybody's not a therapist, and you don't really have to know that part, but one of the things is that TFCBT does have certain not modules, what are my words? Components that are part of the model that help guide the therapist move towards using those components that are so important to ground the child. So you can see that baseline assessment, getting that assessment, knowing where the child is the core component. And then the bottom one is weekly caregiver involvement is optimal. And we just really want to emphasize that, because we still have beliefs that a therapist is going to fix the child. We still have the hope that you can drop off your child with that therapist and they're going to be fixed. And so this model, the caregiver is integral to it, both learning the steps along the way, learning the parent management strategies, learning the affect management. So the kid learns them and the parent learns them. The parent learns how to support the child with those skills. And as you can guess, when we have complex kids, our caregivers often don't have the skills themselves. So they are learning some of this along with their children, and then we can support them being a lead in their family. So that first part is all of the kind of skill building. It doesn't go from one to another. You're weaving these, especially thinking about those kids we're talking about with complex trauma. They're still maybe in unsafe places. There are still things going on. There are still struggles. But while you're doing that, you're learning the skills and using those kind of in your daily life as you're moving towards that really important trauma processing place. But the therapist is working along, partnering with the child and family of using the skills, supporting the skills. You're teaching things like that, relaxation, mindfulness, how how to manage your energy, and then coping skills, being able to identify your feelings and use some language for that. So those are all the skills, as you're going forward. So they have it kind of a third. But again, these are guidelines so that folks move through the model. But it doesn't mean that you do one thing, one session, and you never talk about it again. That's what that gradual exposure is. Little bits at a time, you're talking about what happened and starting to make your story before you get to the trauma narrative. And then the last part, which is also sometimes the first part, enhancing safety. You have to make sure that the child and family are safe. And so sometimes that has to go first. So why are adaptations necessary? Because we talked about these are really challenging kids. They have ongoing struggles. It's not that the traumas are over or things are happening that mimic and trigger some of their trauma. So they are often kids who have been so hurt they don't trust anybody. So like I might be the best therapist, but they're not going to trust me coming into. So there's extra work of engagement with kids. So you need some adaptations, and we talked about dysregulations throughout everything they're doing in their daily life. So that you have to do some extra work with these kids with complex trauma so that they can go forward. And the other thing, and I was at the TBRI talk yesterday, just the reminder that if I'm 17, I may be emotionally like a 12-year-old. So you look at me and I'm a grown man and my emotional functioning is 12-year-old, and really understanding that those kids that have untreated trauma often look like younger kids, but it's kind of hard because they're doing older kids kind of things. So this is, again, just that assessment is so important with these kids, not just a trauma screen, but what's going on, what are their abilities in school, and what are the other symptoms they're having, trauma symptoms, but what other things are going on in the family. And it's not I'm going to talk to this kid and then I'm done with my assessment. It's like, I need information from the teacher. What does this kid look like at school? Where is his strengths, and where are the things like, whoa, we have some more evidence for our places where we have to look at safety. So getting information from all kinds of folks. Sometimes it's like if a kid has come from a biological home in with a relative caregiver, you still want to talk about where the other places, get information from there, because kids don't look the same in every environment. So again, getting all those clues, and then just being mindful as you're doing the assessment. It's not like, okay, today we're doing this. Kids have to be prepared, and so sometimes they get flooded and overwhelmed. So it's like using relationship, helping support them so that they're not blown out of the water by just coming in your office and starting the treatment. So trauma, like we talked about trauma screening and trauma exposure, and there are measures for what the trauma exposure is, but guess what? Our kids with complex trauma, well, you could check the box for all, 10 ACEs. That's going to tell us much. And often the kids with complex trauma, such a disorganized story. So partly you can use an assessment strategy of just doing a timeline, where'd you live here? Which grandma did you live with? When did the police, and help them kind of just tell the episodes of the story. And again, not to go in depth and process all of this, but just starting to help with some organization of a really complicated life and asking about things like, so, okay, you came into custody, but what did that mean? Did the police come to your house? Were you at the ER? Again, not to tell the whole story, but get some of the facts in an organized way. So assessing complex trauma, as we talked about, is not going to have just one way of getting the domain. So you also, it's like some of the youngest kids, we make sure that we're getting those TEIS assessments, the speech language assessments, the OT assessments, trying to look at all those domains, and not just the behavior, but where are all of the other pieces of development at. And one of the things that we often talk about and maybe is underused is this idea of okay, you have a trauma screen, but what are the other things, the other strengths and challenges the youth is having? Because just because you have trauma doesn't mean you don't have other challenges. And so using a broadband assessment for us, psychology broadband means like, but you're looking at internalizing kind of symptoms and externalizing, not just the table flippers, but what does it look like? What did they experience? What did they report for how they're feeling? Are they scared? They're overwhelmed? And sometimes, well, always we do evaluate, like from the child's perspective, if they're oldest, so they can old enough, they can give us their own information. Then we get one from the parent, the dad, the mom, the teacher, sometimes, the child care provider, because everybody has a different relationship and sees different things. So the more information we have, the better. But some of these are just examples of broadband. There's another one that, what's it called? Differential ability scale is the one that they use with Melissa. Difficulties questionnaire. Anyway, strengths and difficulties questionnaire is non-copyrighted measure that folks can use. Some of these, there's a cost, like the BASC system and child behavior checklist, there's a cost. So we also try to find measures that folks can use without a cost. Go ahead.
Excuse me, can you repeat that assessment? I was trying to get to where I could write it down.
Strengths and difficulties.
Okay, thank you.
Yeah, and we can send it to you, or just let us know. And so and I think one of the things we talked about on this slide was just making sure folks see that there are multiple tools for a trauma screening too. A lot of folks use the CATS, with some child and adolescent trauma screen. And because that doesn't have a charge, we have worked really hard of finding good measures that we understand that our providers have challenging budgets. So that's one that doesn't have a cost. A trauma symptom checklist for children is often used, but that one has a cost. There's one other one I can't think of it. One besides the CATS.
The CPSS, Child PTSD Symptom Screen. Another.
Yeah.
There's a revised version for the DSM-5. I think that one is also free.
Yeah.
CPSS.
So we just really want to promote assessing the kids and the families before you start. I think, was this yours? Yeah. Yeah.
Okay. Questions so far?
I do have a question.
Yeah.
So as far as the psychosocial assessment, is there one preferred over another, a certain one, anyone that captures? Because I know we captured everything except for the teacher. I thought that was interesting.
Yeah.
From the educator, because we hadn't nothing.
Yeah, they have a different perspective, right? Kids are different in the classroom than they are at home sometimes. So yeah,
Thank you.
But great question. Yeah, there's no one sort of magic tool. There's lots of things out there. All right. So in terms of adapting TF-CBT for kids with complex needs, rather than sort of following the map that Dr. Moser showed with the kind of one-third of this, one-third of this, one-third of that, the recommendation is really to do more phase-based treatment. So you're hitting all those components, but you're probably hitting them several times in each phase of treatment. And so what I'm going to do is sort of go through each of those phases and talk about some specific strategies for adapting the model to kind of fit those phases. It's treatment, is sequential. There's an order to how we do things, and there's a reason for that, but it's not always linear. Like, it doesn't mean that we always go this to this to this. I mean, they do kind of build on each other, but we're going to go back and forth between components based on the child's needs. And that often evolves sort of over the course of treatment, right? So, but the developers have recommended kind of three phases with kids with complex needs in TF-CBT. So the first kind of phase is that engagement, safety, and stability. So Dr. Moser talked about trust and the difficulty that a lot of these kids have with trust, understandably, right? Making sure they're safe, psychologically, physically safe, and stable, ensuring that before we move on to trauma processing, and then at the end, sort of working on continuing that safety and future development. So these are all the components in TF-CBT. We call this practice. This practice acronym kind of lists all of the main components we use in TFCBT. Parenting and psychoed, relaxation, affective regulation, cognitive coping, trauma narrative and processing, in vivo exposure, conjoint sessions with a caregiver, and enhancing safety and development. So in our typically developing kid with like maybe one trauma, but everything else at home is okay, we would follow this pretty much like this, right? We might, alter some things here and there, but we're essentially going to follow this model. With our kids with complex trauma, we're going to go through these in sort of each phase of treatment, if that makes sense. So it's a little less sort of scripted and formatted in that way. So each phase of treatment, we do the practice components as needed, right? Depending on the child and family's needs. So for example, during the first phase, we might do everything except exposure, right? But our sort of ultimate goal is engagement and safety. So whatever components we need to do to help build that engagement and safety, we're going to focus on. So phase one, facilitating that engagement, okay? Fostering that engagement, as we talked about, really relationship building with these kids who have a hard time trusting. So spending extra time on this, right? We might not need to spend so much time on engaging them in the treatment process if they already are securely attached to their caregivers and everything's sort of okay otherwise, right? But with their kids with complex needs, if they've had that maltreatment at an early age, that complex trauma, that's going to take more time. Making sure that they are physically safe in their home, that they feel psychologically safe, working with caregivers to help enhance that sense of safety. And just doing some basic education about trauma like we would with other kids. We're going to let them know about how their history of trauma has impacted them and why that's connected to why they have a hard time, trusting people, and sort of helping kids understand why they're having the symptoms that they're having, right? And then a lot of caregiver stuff. So as Dr. Moser mentioned, we really like to have caregivers involved as much as possible. This is trickier with this population because their placements move, their caregivers might change. We might need to spend some extra time with caregivers, helping them understand how important their role is in trauma-informed treatment. Foster parents, for example, well, I didn't have anything to do with their trauma. They're just living with me now. Why do I have to be part of treatment, right? It's a good question, right? Well, because you're the parent right now, and you might not be the forever parent, right? But you're with this child now, and we need you to help us help this child, right? That the therapist they're not with the child 24 hours in the way that a caregiver is. So working with caregivers around that sometimes takes extra time. And so in working towards safety and stability, we are going to teach them relaxation, kind of meet the child where they are. We tend to think of things that are relaxing as, sitting calmly, closing your eyes, deep breathing. That doesn't work for every kid. Sometimes being still is a trigger, right? So help them figure out what works for them. Sometimes movement works for them. Sometimes, doing other activities works for them. So meeting kids where they are for their relaxation, helping them with the affect regulation, the cognitive coping, we're going to do all of that. Our conjoint sessions, so even though in the model it shows that towards the end, we really are doing conjoint sessions from the beginning. And so we might need to spend extra time working on that for our kids who are having a hard time trusting. So we usually will spend time with the caregiver by themselves, so educating the caregiver about what we're teaching the child, maybe working with the caregiver around their own beliefs or thoughts about what happened to the child and why, and sort of helping them get to a place where they can really support their child. And then doing sort of brief but positive time together in a session. So maybe we're meeting with each of them separately, and then we bring them together to do an exchange of praise or something like that. That's positive, that can help build the trust in that relationship. Rapport may be easy, trust might take longer, right? So some of these kids are very good at sort of like, okay, I know what I'm supposed to say and what I'm supposed to do in this moment, but really getting to that trust can take longer. So we know that. We want to allow time for that. Titrating to the relationship. Relationships themselves might be a trigger, right? If kids have had a lot of experience of maltreatment by loved ones, Then getting close to somebody can be a trigger. We see this with foster kids all the time. As families kind of start to get close, things get more real and more family-like, that can be hard for them. So we're going to titrate to that directly. We might start out less directive and less structured in the beginning than we would maybe for another kid, if they just need more of that time and space to build that trust. Obviously, we're going to address imminent safety concerns. If there's anything going on regarding self-harm, right? We want to address that right away, get that under control. If they're experiencing bullying at school, if their community is unsafe, any of those kinds of things. At-risk behavior, we're going to address that right away. Develop a safety plan in concert with their caregiver, okay? And whoever else on the team needs to be part of that. If we need school involved, if we need aftercare involved, whatever that might look like, and helping the youth identify who they trust. Like, who are your go-to people? How can we include them in this, right? That's going to help them feel better about that plan. So in the psychoed, we talked about kind of defining what is stress, what are common reactions to stress and trauma, helping the youth and the caregiver understand the dysregulation. So Dr. Moser talked about this. This is a hallmark of complex trauma, this emotional and behavioral dysregulation. So helping them and the caregiver understand that this is a stress response. This is not willful disobedience. This is not the kid trying to be a pain in your ass, okay? They're just dysregulated. Their brain works differently than other kids, right? They regulate things differently. That sometimes the maladaptive, that a lot of these sort of disruptive behaviors and maladaptive behaviors really are just an attempt to survive, and that some of these behaviors may have been very effective in another setting, right? They're not so effective now, and we want to help the child understand that and help them find other ways to get those needs met. Teaching them new ways to manage stress, okay? We also want to do more education based on their situation. So again, meeting the child and the family where they're at. So we are working with kids in foster care. What information can we provide them about the system and how things work? Because it's incredibly confusing, right? So what role do all of these people play in bringing in a caseworker to help have those discussions, right? Who are these different players on your team now, and what do they do? And what are your rights? What can you expect from them? Those kinds of things. You know, if there are court dates coming up, talking to DCS about what can we tell a child, what's happening, how can we keep them informed in a way that's developmentally appropriate, of course, right? But just doing some of that basic education, and including caregivers in this as well. So especially if it's like a relative caregiver or somebody who's not that familiar with the system, but even sometimes foster parents or like new foster families might not understand everything that's going on in the system. So we can do that in CBT through therapy, helping to provide that education. Kids whose parents are engaged in substance use. So many of our kids are brought to care because of this, right? This is a huge issue in East Tennessee, especially, but lots of places, right? So helping kids understand what that means, especially if they're younger, but even if they're older, I think they need some help sort of understanding the impact of substance misuse on their caregivers. That can be such a complicated and confusing thing for kids to understand. Like I can't go home because they're using drugs and they're choosing drugs over me, or all these things that kids can think, right? That their parents don't love them, that they don't care. All these kinds of distortions they can have, but providing just some basic education about the impact on a person's brain when they're using drugs, the process of addiction, and how that is a physiological thing that's happening to their parents, and it's affecting their decision-making ability. Just because your parent is using drugs doesn't mean they don't love you and they don't care about you, but this drug is so powerful that it's really impacting how they're functioning as a parent, and they are not at their optimal self right now, right? Kind of helping them understand those things and giving kids a place to kind of process some of that. Kids with developmental disabilities, sort of education about what that is, what that means, what does this mean for your future? Those kinds of things. What resources do you have available? And again, for caregivers too. Problematic sexual behaviors. This is a big one. So for young kids, kids under 12, this is something that is very easily treated, but people are very scared of it, right? You put kids and sex in the same sentence, people don't like that. We don't like that. So it's important for us to educate caregivers about problematic sexual behavior in young kids, that this is a behavior that they have learned somehow, some way, but it can be unlearned. We can give them other skills. They're doing this to meet a need. And it's not a sexual need in the same way that it is for adults or adolescents, right? These kids do this behavior for other reasons. So let's figure out what that is. Usually it's to manage a feeling, right? They don't know what to do. And so they've seen this thing or they've done this thing. Help them understand that this is just a maladaptive coping strategy and we can teach them new behaviors. Most kids with problematic sexual behaviors can be treated by an outpatient therapist. Okay, so therapists can work with families to help them set up rules about touch, okay touch, not okay touch. If there are house rules about who can be in what room, doors need to be open, supervision, monitoring. If you use all of those tools, it really can be effectively treated. Okay.
Chris, I think there's a question over here.
Yes.
For the problematic sexual behaviors, is that touch, good touch, bad touch, is that child on child or self?
Either.
Either.
Okay. Yes. Good question. So if you have a child, for example, who's masturbating or who's touching themselves at school, right? Everybody's not. You've all heard of it, right? Talking to the kids about when and where is it okay to do that, right? Masturbation, we know, is a normal, healthy thing that kids do. So let's set some parameters about when and where we do that. We do that in private, in our room. We don't do this at school, et cetera, et cetera. Yeah, great question. Parenting. So again, this is the parenting component of TFCBT is more complicated with kids with complex trauma, and particularly those who had different caregivers. So we really want to think about it as more than just one person. It's really a team. It needs to be a team, right? Because of all the areas that are impacted, right, by kids. So really think about it as a whole system, kind of identifying those key people, identifying those relationships that a child has that are healthy or that we want to maintain and kind of keep those going, as well as developing those new healthy relationships. And again, helping caregivers understand how important their role is, helping this child. Relaxation, we kind of talked about, kind of meeting the kids where they are. Every kid's going to have different strategies that work for them. That's true of all kids. So with these kids, same thing. We want to spend some time kind of helping them identify that kind of state where they're comfortable. Utilize skills that they might have already been using. Affective regulation, also more complicated because they might have these additional issues about emotional numbing. So it's just easier for me to check out and not feel, right? Or dissociative responses, or the sort of affective storms where I'm completely overwhelmed with all my feelings. And so again, helping them see that they developed that response for a reason, right? That the environment they were in or the experiences they were going through resulted in some of this stuff. But let's figure out some more healthy ways for you to be able to feel and be in touch with your feelings and be able to manage them effectively, right? That it's okay to have feelings, good and bad feelings, right? All feelings are valid. How can we learn to manage them effectively? And kind of letting them know emotions play a role, right? There's a reason we feel this way. There are clues. They give us information about what's happening in the environment and how we're responding to it. So we don't want to ignore them. We don't want to push them back. We want to pay attention to them and then figure out how to manage them. Some kind of things we like to talk about with feelings, the role that they play. All feelings are valid, as I mentioned. Different feelings can have different intensity levels. So sometimes for our kids who are really dysregulated, they're afraid of feeling anything because they're used to it sort of being all the way up here, and letting them know that you can have some of that feeling. Doesn't always have to be at a 10, right? And you can tolerate it if it's at a 5. So let's figure out how to help you get it to a 5. Multiple feelings at the same time. That's okay. That's normal, right? But we have lots of feelings about different things. Negative states are temporary and can be tolerated. And if we can communicate our feelings, that's one way we can get support. That's actually a strategy for helping us manage our feelings is by being able to talk about it, telling other people. Other people can help support us as we're dealing with these feelings. Any maladaptive coping strategies that they might be using, we want to address that. So we mentioned the problematic sexual behavior, but also aggression or self-harm. Like that's one skill that you've learned. Let's figure out other healthier ways for you to manage those feelings. And again, if they're using something that's maladaptive, we still want to validate the feeling, right? Your feeling is valid. It's okay that you're distressed. It's okay you feel upset about this. You feel sad or mad. We just want to help teach you more effective strategies. Okay, cognitive coping. This is not terribly different. We teach a triangle in TFCBT, the connection between thoughts, feelings, and behavior. We're going to do that too with our kids with complex trauma. Sort of applying those to the current stressors. We sort of teach this cognitive coping with kind of day-to-day things. And then once we've done some trauma narrative and we start processing, we kind of come back to the triangle and look at unhelpful thoughts related to the trauma. So we teach kind of these basic skills up front. Sometimes with younger kids, we have to be more creative in terms of how we teach the concept of a thought, right? And what a thought is and how thoughts affect our feelings. So we can use things like cartoons. I have found cartoon bubbles very effective for young kids. They're used to graphic novels and things like that in school, and you can draw little thought bubbles to help them understand. Role plays and other concrete strategies can be helpful. For conjoint sessions, so these sometimes can be triggering for our kids. So if they're used to being maltreated by caregivers, again, it's hard to trust new ones, and sort of any kind of vulnerability or closeness to a caregiver can be triggering. So we always want to be mindful of kind of how the child is responding to those caregiver sessions, those joint meetings. And again, starting out just with very brief time together, focus on something positive, and then sort of gradually over time, lengthening those conjoint sessions. But being attuned to that. So this just sort of illustrates that for our kids with trauma history, sometimes that signaling of care is a danger sign to them, and they don't trust that. So we just want to be aware of that and sort of try and do some counter conditioning so that we start to pair positive experiences with caregivers. All right, so our goal obviously with caregivers is to improve healthy relationships, right? Give them a chance to develop a healthy relationship with a caregiver. Therapists in our model, we sort of want to model to the parents how we want them to be with the child, right? So there's sort of this circle of, I'm going to monitor, kind of being an emotional container, being supportive of you, praising you, so that you will do the same thing for the child. And part of what we talk to caregivers about are being the coach, right? Like therapy is not going to last forever. So I'm going to teach you some things, but really our goal is for you to take this home and do with your child, right? Moving forward, your child's going to learn these skills, but we want you to be their coach, to encourage the use of those skills, to praise them and reward them when they use those skills, right? You're carrying the torch forward. Okay, so moving to narration. So how do I know when a child is ready for the narrative? This is a common question with all of our TFCBT cases, because we kind of start with those stress inoculation skills, right, before we move into narration. But with complex trauma kids, it's more complex. So we want to see that they've made progress before we start trauma narration, that they've actually been able to use some of these skills. There's been some uptick in what we've taught them. We don't expect them to be 100% perfectly stable and insightful. That's not our goal. Our goal is they've made some progress. There's nothing in the near future that we can foresee that's going to be a major stressor. So, if a child is preparing to change placements or change schools or some big thing like that is coming up, we're going to hold off on doing trauma narration. But we just want to make sure that they're relatively stably unstable, if that makes sense, right? So not like symptom free, but that they've made some progress and they're able to use some of the skills, right? Even if they still have dysregulation, even if they're still having some things, they're able to utilize their skills, right? Perfect stability not required. That they're able to sort of manage the crises of the week, that we're not every week coming in sort of dealing with, you know, what was the last major issue, that we're sort of past that point where we're working on skills. We hear this sometimes even among therapists who maybe don't have a lot of experience with complex trauma, that they worry that they need to be stable before they can start the narrative. A lot of kids won't reach stability until they have processed their trauma, right? So we're not waiting for them to be 100% stable to do this. They have to have some skills and be able to use them with support, right? But for a lot of kids, they're not going to be better until they're able to make meaning of what happened to them, right? And be desensitized to that trauma memory. Okay, so facilitating the trauma, when we're ready to start this. So we're going to continue using some of our practice skills, our psychoed, our parenting, our relaxation and coping. We're going to start the narrative processing. We do in vivo mastery. This is real life exposures for kids who are avoiding things that are safe, but that we want them to be able to do again. So if you have a child who's not going to school because they were bullied in school last year and now that's a trauma trigger, we want to get them back in school, right? So we're going to do some gradual real life exposures. We're doing conjoint sessions still. We're still focusing on that safety as we're going, and then we're going to do the processing the narrative. So our psychoed piece of this phase is, why do we do this? Why do we do a trauma narrative? Why do we have you tell your story? Makes me really uncomfortable when I tell my story. Why are you making me talk about it? Right? We want to give them a rationale that this is going to help you, actually. And we have analogies and different things that we use to help kids understand why we're doing this. So we may need to spend some extra time on this. We want to make sure they understand the rationale before we jump into it. Desensitization is a big reason we do this, right? So we're desensitizing kids to the memory of what happened so that they can think about it, be reminded of it, but not be overwhelmed by it, right? To not have it control them. So that's a big piece of what we're doing. But with our kids with complex trauma, they might need more than just that. They might need more time working on the meaning of what happened, understanding what happened to them, why it happened, how it's impacted them, right? Especially because they've had multiple traumas, right? So we may need to spend more time on this, not just telling the story till the story gets easier, but also spending time sort of exploring, what's the impact of this? How is this impacting me? How is this going to impact me moving forward? Not just in my own mental health, but in my relationships, right? Sort of talking about how the past informs the present. So we want to spend a little more time on that. And then also sort of, in particular, the impact of chronic trauma, if that's what they've experienced, or the impact of parental substance use. Okay, so just doing some more education around that. With parenting, we're going to talk about the fact that their child's going to be doing a lot of hard work during this phase. And so things might get worse for a minute. That's pretty normal. As we start to talk about their story, they start talking about difficult things. They might get a little more dysregulated, might need to use some of those skills. So we want to prep caregivers for that, right? Be ready. Doesn't mean that therapy is not working. It means that they're actually doing the hard work, right? So prep parents for that. So they are ready to respond to it and that they don't sort of give up on what you're doing. Okay, as I said, we're going to continue to utilize our skills as we're processing the trauma, right? So once we get into narration, it doesn't mean we stop doing relaxation or we stop doing affective regulation, of course. Okay, so we're going to continue that. Our complex trauma kids may have less capacity to tolerate trauma, so we might need to go in smaller chunks. Our gradual exposure might need to be really gradual, right? Like really baby steps. Give me 5 minutes and then we'll do some relaxation, right? We might need to break it down a little bit more. We need to help them with some of that emotional awareness. Maybe they did fine kind of in the earlier part, but now as it's getting to the trauma, they're sort of reverting back to some old strategies. And so we're going to help them work through that, help them to be able to feel their feelings and manage them. in a very proactive way. So trauma narration is challenging for lots of reasons. And Dr. Moser kind of talked about the lifeline, like so many of our kids have so many different trauma exposures, or it happened for so long, and there were all these other intervening things. So that can be complicated. For some of our kiddos, the trauma may have happened a long time ago. Sometimes they don't get into therapy until years later. And so it can be difficult to remember what happened, or they might not have explicit memory of some of the things. We know memory lapses in trauma is normal. We expect things to be disjointed, and so it just might be even more so with our complex trauma kids. And certainly, we're not going to do individual trauma narratives for every single event that has happened to them, right? It would be probably not helpful. First of all, it would take a long time. Not sure how helpful that would be. So we have to figure out other ways to sort of process that memory. So part of what we do is kind of let the child decide, like, of all the things you've been through, which ones are the most salient? Which ones are the most bothersome for you? And it's not always what we think it's going to be, right? Like me as a therapist, I might think, that the sexual abuse was the worst part, but maybe for the child, it was the removal, right? Not being with my family, not being with my siblings, things like that. So we let the child tell us, right? What are sort of the most salient things? And we can do desensitization around those sort of hot topics, right? The ones that are the worst, but we don't need to do it for everything. And maybe we spend more time on kind of underlying themes. Like, what are some common themes that you see come up as we sort of lay out your timeline? That maybe it's the theme of rejection. Maybe it's the theme of being hurt by others. Maybe there's some other theme that we want to identify and kind of process that, right? Do some cognitive processing around those themes and how they're impacting their functioning, and coming to a more healthy and realistic understanding of their life and their identity, right? If they've got a lot of distortions, I'm unlovable, I'm not worthy, all those kinds of core negative beliefs about themselves, we're going to work to change those beliefs to more healthy. For our young kids, sometimes younger kids with or without complex trauma incorporate fantasy into their story, and some things that didn't necessarily happen, kind of magical thinking stuff. We tend to not do much of that. Like, we tend to kind of let them have that because it's age appropriate. As long as we have, some of the real details in there, if that makes sense. Kind of helps them make sense of their story, to have, Superman fly in at the last minute and catch that. That's probably okay. All right, so in vivo mastery, I talked a little bit about that. And again, we sort of play it as kids need it. I did want to say one thing about caregivers. It's optimal, but it's not required to have caregiver involvement. So ideally, we know kids do better if they have caregiver involvement, but if you don't have an appropriate caregiver, don't use them, okay? It's better to just treat the child by themselves than to have a caregiver who doesn't believe them, who questions them, who doesn't support them, right? So if you have one of those caregiver, a red light caregiver, we call it in CBT land, then it's better to just not involve them, okay? You can use other people besides a parent or a foster parent. You can, if they love their DCS worker and want that person involved, you can involve that person. But make sure they're appropriate. And we're always going to meet with a caregiver separately before we ever have them hear the narrative or do anything like that. So the therapist is going to vet them to make sure that they're appropriate. We certainly don't want to force caregiver involvement just because the manual says I should have a caregiver, right? Only if it's an appropriate caregiver. And also, I will say TFCBT is for non-offending caregivers. So if your parent was hitting your child, not appropriate for this model. There are others, CBC, CBT, come back after lunch, we'll tell you about that. But TFCBT is non-offending caregivers, okay? And then safety. Again, we're always checking in on safety. So if a child's go-to coping skill had been self-harm and they're getting a little more dysregulated, we're going to make sure we're monitoring for that and that we're utilizing other coping strategies for a child. Okay. how we know we're done when they're able to kind of tell the story and not get as dysregulated, right? Doesn't have to be perfect, but they're able to use some coping skills. They're able to sort of distinguish between past and present and understand the impact of the trauma and have kind of a sense of meaning about it. Right, we are out of time. So, questions? Went through that really fast. And thanks for being such good listeners. Any questions, comments, concerns?
I'll ask one.
Yes.
So do you see an overuse of psychiatric disorders being labeled of the children and youth with unresolved trauma processing? So what is the prevalence once they go through this, that those labels are taken off?
Ooh, good question. Don't know. I don't know if that's been studied. Like if they, the other diagnoses start to drop off. I mean, I think once you get a trauma-informed therapist or team, which could include a therapist and a psychiatrist, once you have a trauma-informed team, then we tend to see those drop off. But yeah, like would that change when they go see other providers afterwards? That's a great question.
I'm just curious.
Yeah.
If there's that prevalence issue.
Yeah, I don't know. Have you seen anything?
No,
Like
I know. It's a really good question because we're always like, oh, we're going to help them, get back on developmental track, be able to engage with caregivers, all those things. And I don't know that the diagnosis thing is really a challenging issue because the other thing is they follow kids regardless of what they look like. Like there's not always good assessment if they had, 4 diagnoses before, the next person looks what they had before and like it carries on. So it is a really challenging issue when kids get better. What happens with those diagnoses? But I haven't seen anything about it.
And the reason I was asking is from a profile perspective. So as we're looking at life gives or looking at best places going forward, if they have ODD or there's other things that say, oh, this is on paper, it's like a bad kid or
Right.
a kid, when in reality it was just unresolved trauma. Now that the trauma has been resolved or that they're able to move, there's not this, they're not that high acuity.
right.
They're now
Right.
there's that level left. So,
Right. Well, and I think this came up from one of our COE cases where I don't remember if it was the foster parent or maybe it was DCS who talked to a provider about doing that. Like, can we update these diagnoses? And I think they just sort of asked, can we get current records that reflect that so not everything gets carried over all the time. So that's certainly something I would think about doing if you're looking at a kid who seems to have some inappropriate stuff. That's their current provider. Ask them if they update that the records.
And that makes it so challenging too when you're trying to do a paper review because it is that caregiver-child relationship. I can have a kid who looks terrible on paper, but if I give them a caregiver that actually meets their needs, they look like a totally different kid, right? And so it's not, the history on paper sometimes is
Yeah.
I have a really basic question. I feel silly asking it.
Please don't.
It
Please
was,
don't.
it was early on in the slides. I just can't. It just struck me, and I'm wondering if you can unpack it a little bit.
Huh.
It was just a statement that said, the resources normally used for development are instead used as survival. What are we talking about there?
Like internal resources. So instead of like being able to calm myself down and pay attention in school and use my frontal lobe, right, to think about things, I'm activated by my limbic system because I'm in survival mode, right? And I'm like hypervigilant, like, okay, what's the next bad thing that's going to happen? Who's going to do what to me? What's going to happen when I go home? All of that energy is taken up by that instead of other
I
things.
didn't make the connection to like cognitive and emotional resources.
Yeah.
Thank you.
Yeah. Great question. Thank you for asking. Anything else?
What do you say to a parent who's struggling with parenting a child who's been through trauma beside a child who maybe has not, and helping both understand like how the parenting may look a little different and the expectations may look different?
Yeah, a lot of education about that. So that's a great question and a common issue for a lot of our parents, right? We say, well, I have my own biological children and they're just fine. Like, how come I can't parent this child? Because this child is different, right? This child doesn't have the same attachment that your own children have to you. This child has been through maltreatment at the hands of caregivers, which means X, Y, and Z, all all the things, right? It means that they not only have a hard time attaching to you, they have a hard time trusting you, they have a hard time regulating themselves, they have a hard time doing all these things. So I often will say, this child's brain is different than this child's brain. It works differently. So you as a parent have to respond differently, right? We have to spend a lot more time on working to just day-to-day stuff, regulating this child, regulating their behavior, doing more. They need more supervision. They need more hands-on. As Dr. Moser said earlier, they're younger emotionally than they are chronologically. So let's think of them as a younger child. Sometimes that helps parents think about them. Oh, this is not really a 12-year-old. This is a 5-year-old. Just a lot of that kind of basic education around that you are going to have to parent them differently because they're different kids based on your experience. It's a common issue. And I think it's also helpful to validate the parent that asks that. Say, yeah, I see why you say that. Yeah, you're the same person, same house. Why is it so different with this child? That's why sort of, validate their own confusion about that and why that doesn't seem to make sense. Okay. Great questions. We'll hang out for a few minutes if other people have more. Thank you for your attention. We appreciate it.